Thanks for having me here today. And in interest of time, I'm going to talk. I will probably end up talking too quickly, which I apologise, but this is one of my baby trials after 20 odd years, and there's an awful lot I could say. So I'm going to talk about Dixel. Lots of words, break some of it down in a bit. Thankfully, our protocol paper was published last week, so there's a lot of information in the protocol paper and on our trial website. So cellulitis is a common bacterial skin infection, and it can cause significant pain for patients that have it. And in England, we have over 300,000 related attendances at emergency and urgent care departments. So this, emergency settings, and quite a high proportion of these individuals end up being admitted to hospital. And antibiotics are the first line of care, given routinely. And they might treat the underlying infection eventually, but they don't deal with immediate inflammation. So they don't deal with the patient issues when they turn up to emergency medicine. And importantly, in the UK, about 20% of individuals having seen a GP or turned up to the ED setting, they need to come back because they're still in pain and they're still not actually managing their symptoms. So steroids, widely used around the world, are often given to reduce short-term inflammation and pain for all sorts of different conditions. And some of you might remember about the recovery trial to do with COVID. And there's been some little, and I mean little studies, which have looked at using oral steroids in addition to antibiotics, so in addition to usual care, to help manage patient symptoms like pain. And nationally and internationally, some clinical guidelines already suggest trying steroids, but the evidence is very mixed, it's not very high quality. So we need high quality trial evidence for our healthcare decision makers to make policy. So really early on, we knew who we were trying to get to. We knew who our patient group was. We were looking at adult patients who are turning up at emergency settings, urgent care settings, with a diagnosis of cellulitis. So we knew that bit, that was easy. And we knew what we were trying to look at, our intervention. So we were on dexamethasone. It's only going to be 2 tablets, 24 hours apart. Really simple. Now, I also don't really want to look at merit here. We also knew what our comparator was going to be. It was going to be placebo, and I'll come back to that in a minute. What we didn't know was what to actually measure, what was going to be our primary outcome. And part of the issue there was there wasn't a relevant core outcome set. So there was work ongoing, but there was no relevant cause for us to use. So we kind of went back a step and thought, well, what's the context here? Emergency medicine, these are patients, they tend to be a bit older. They're coming in to ED, they're anxious, they're unwell. They're a bit older, so they may have other issues underlying. The setting, emergency medicine, if you've been there on a Saturday night, it's chaos, to be quite frank. Really difficult to do research in EDs. Research staff come in, come out. They generally work 8 till 4. They're not available in the evenings. They're not available at the weekends. And yet that's when a lot of people will turn up to emergency medicine. We knew our trial treatment, dexamethasone, great, but that means it's a drug. It's a drug trial, so then we've got all the regulations to consider. And certainly in the United Kingdom, there are very few drug trials have been run in EDs. So that was another thing we had to think about. And we had to think about the placebo limit. Now, one of the interesting things with running trials in emergency medicine is people come into ED, they want to go home as quickly as possible. They don't want to come back to hospital, thank you very much, unless they really need to for clinical treatment. So we had to think about how we were going to follow up these people using remote approaches. So we needed a really simple trial. It needed to be simple for the sites, for the staff, and the patients. So we wanted to design a pragmatic trial, great, with decentralised data collection. So we knew what we were trying to do. And one of the things we spent a lot of time thinking about was research inclusion. So as I said, cellulitis typically affects older adults. It also affects diabetics, and it also has quite a high rate of people who inject drugs. So these were 3 of the groups we particularly wanted to try and include in our trial. And in parallel to those groups, from a sort of wider perspective, we knew from some previous work within the team that trials in cellulitis in the past had actually been quite exclusive of people with coloured skin. So we wanted to think about them as well. So going slightly sideways, PPI. So patient and public involvement has been fundamental to this trial. I cannot reiterate that from the outset. And we were really lucky because we had a really young early career researcher, a medic, who drove a lot of the pre-work, and he did a huge amount of PPI engagement before we got to a trial design. And these are just some of the groups he worked with. And the message from them was really, really clear. We had to design our trial out to ensure that the research was going to be relevant to all the groups we wanted to apply our findings to. It's a bit like what Merrick was saying. So we go back to skin and skin tone. Previous trials in cellulitis have often used redness or erythema as a primary outcome. Sounds good, but actually it doesn't show that well on people with darker skin colours. So we didn't want to do anything that would exclude people with certain skin tones. And this came through time and time again with our PPI discussions. So we kind of ruled out, we don't want to do that, so what do we want to do? And we went back to the literature, and what we did find is there had been some work to try and ask patient groups, patients with cellulitis, well, what matters to you? What concerns you? And they talked about pain, reducing pain, they talked about quality of life and a few other things. So we took that work back to our own patient groups, and without any shadow of a doubt, what they wanted to deal with was their pain. Great, so we've got our primary outcome, it was patient-driven. So I mentioned people with diabetes, really important group, often excluded from trials of steroids because people with diabetes are at high risk of infection, so higher risk of cellulitis, but in parallel, dexamethasone or steroids in general can increase blood sugar. So a little bit of a challenge there. So we worked with diabetologists to try and come up with a plan of how we could include these individuals because we felt it was really important because if we showed that steroids work, it's likely somebody with diabetes turning up to ED, clinicians might want to prescribe. So we worked to produce additional training and paperwork for the clinicians to help support them. We provided additional patient information sheet and how they could think about things and how they would contact a clinician if they were worried. And we kind of planned out to always kind of monitor quite carefully severe hypoglycemia. So we came up with mitigations up front as part of our design, which would allow us to include this group who are often being excluded. People who inject drugs. So a community, certainly in the UK, that are regularly excluded from clinical trials. Not always intentionally, but because of the trial designs, it makes it quite difficult for them to be included. So again, Gus, our early career researcher, spent quite a lot of time trying to kind of listen to this community and individuals that support people who inject drugs. So again, we tried to come up with ways to try and encourage and support including this particular group of people. So we planned to give sites additional money that they could choose how to spend. So we weren't telling them, go and spend it like this. They would get extra money that they could choose to invest in a support worker or to go out to visit these individuals wherever they had to be, and also to kind of cover a bit of extra time. Great. What about the individuals? Well, we'd already decided we couldn't ask people to come back to EDs to follow them up. So that was already a slight advantage. We knew what our primary outcome was going to be. It was going to be pain scores, and I'll come back to the two-way SMS in a minute. And we also planned to offer them a supermarket voucher. So in the UK, you can't give cash, basically, to take part in research. But what we wanted to do was recognise that for some of these individuals, asking them to pay, basically, to use their phone, even though it's not very much, might be an extra burden. So we planned to offer them in return a supermarket voucher as a bit of an incentive, a bit of recognition to cover the costs of the text messaging. And I'll come back to that. So text messaging for us was pretty new as a kind of way of collecting primary outcome data. We've used it in the past in clinical trials to kind of remind people, or please fill something out, or please come to your appointment. But we hadn't collected data using text messages. And we landed on that because we kind of ruled out everything else, to be honest. We couldn't use paper and ask them to send it back because there wasn't time. And email or internet-based felt as if it could be quite excluding in terms of digital inclusion-exclusion. Telephone calls, a good way, been used a lot in the past, but that means sites doing it. Emergency medicine sites don't have capacity to do that. So text messages seem to be, inclusive, efficient, cheap, and not particularly burdensome. So that's how we designed our main method of data follow-up. But certainly in the UK, we're always cognizant of not everybody might have a phone, not everyone might want to use their phone. So we built into the design alternative methods for data collection. And this is a really simple summary of our data collection process. And everything in green, all these time points, were collected by text message. That was the plan. So we would send a short text message out after each of these time points, asking, what's your current pain score? They just hit 1 to 10 back. And then a couple of other really short questions, which again were just very simple to answer by return. We then had some other follow-up time points where it just wouldn't work by text message. So we did those by telephone call. But our primary outcome data was all going to be predominantly by text message. The further outway time points were secondary outcome data, health economic data, and things like that. So if I go back to the PICO, we know our primary outcome now, pain, total pain, we were measuring over the first 3 days, every 12 hours. And we were going to try and do it as much as we could by text message. Great. That means that I come back to the placebo. I'm kind of scared to look at Merrick. So we went with placebo because our primary outcome was a subjective outcome. And certainly in the UK, we at our CTU had just had 2 trials rejected by the funder we were targeting, which were drug trials, which had subjective primary outcomes. And despite us trying our best to argue with them, they were adamant that we had to have a placebo in there. So apologies, Merrick, we did try. Sometimes, as we talked about yesterday, it's about compromise. So some other considerations that we had to kind of wonder our way through. We want to do pragmatic trials. That's what we want. But sometimes there's other things you have to consider, particularly when you're doing drug trials and you've got regulations. So we talked a bit about this yesterday. If you're doing a drug trial in the UK, you have to provide quite a lot of patient information. It tends to be 20 plus pages. Yikes. So we've had experience of working in emergency medicine before, and our lead clinician, who was one of my ECRs, who's now, a prof and leading big trials, his view was if people turn up to the emergency department in pain, they don't really have full capacity to read 20 pages, absorb it, and sign. So we tried to basically say we wanted to show a video. And on the back of the video, given this is an emergency medicine, urgent care, that we would ask them to watch a video, they'd have time to ask questions, they would consent, they get their first dose, and they would be given the full patient information sheet to read and digest when they felt well enough to. Research Ethics Committee refused. Nope, as far as we're concerned, these patients have full capacity, they're absolutely able to read 20 pages before you do this. Okay, so we did include a short summary at the start, but we had to capitulate on that. And then we also had the additional information for diabetics. And it is an interesting dilemma in emergency medicine because often you need to treat people quickly. But research ethics, regulators want you to give people time. So there is this trade-off, which is quite tricky sometimes. As I said, we wanted to offer our group of people who inject drugs or previously injected drugs supermarket vouchers. Research Ethics Committee refused. They said we had to offer it to everybody. Now, this is something we've had before in the UK, and there's 2 sides of it. And on the one hand, and again, this came up yesterday about not being biased towards one group and supporting one more than the other, and we shouldn't sort of make assumptions. We hadn't planned for this as part of our trial budget. Even small amounts when you've got large sample sizes, it's quite a lot of money. So that was an interesting thing that we had to try and come forward with our sponsor. And then women of childbearing age. And this is something that's come up a few times in our trials recently. Again, our lead clinician was really keen to include this group. We felt they really should be included. This is real world. And we went round and round and round in the discussions, I have to say. And eventually we decided not to include them. And that was partly because some of our clinicians were really wary. And some of the discussions with the sponsor got quite difficult. And we didn't want to keep delaying submitting their trial protocol for ethical approval. So our decision was to exclude them in the beginning and try and assess whether it was a barrier to recruitment. And if it was shown to be a barrier, then we would try and basically argue with our regulator that we should be including these people. So that was a bit disappointing, really. And interesting enough, one of our sites that we approached refused to take part because of that decision. So again, it's about compromises. Sometimes it can get quite difficult. Other pragmatic elements, and I've put that in quotes, no pill counts. So often in drug trials, we ask people to bring back their kind of empty pill bottles or not so empty pill bottles, and we count them. We didn't. We just asked them, once, did you take your second tablet? That's it. And monitoring. So in drug trials, historically, there was lots of going and assessing things at sites. We didn't want to do that. Emergency departments, you don't want to do that. So it was designed out to minimise, again, the burden on sites whilst keeping patient safety in mind. So we'll go back to the beginning. Dexel trial, we've got all these terms. Multi-centre, great. But the bottom line is a relatively simple trial. It has to be to work in an emergency medicine setting. So we originally planned to open 15 sites in the UK, 450 participants. That was the plan. How pragmatic is it? Thank you for the introduction to Pre-C2, so I'll skip that. In the world of AI, I asked ChatGPT and Copilot. So all I said was, go and find the stuff about Dexel and score it for me. Copilot, look at that. 4s and 5s, yay! I was really impressed with that one. ChatGPT, bit less. Some interesting bits for us to think as a team to think about. And those are the two plots. So you can see we talked about this yesterday, different kind of plots. Not too bad, I have to say, as a researcher, I'm quite impressed with that, quite pleased with that. So we moved to trial setup, the usual chaos when trying to set up a clinical trial, never mind emergency medicine. All sorts of things going on. We did lots of testing to do with the text messages. That was quite interesting. And we had backup plans, which is just as well because AWS went down around the world. So that was fun. We were almost ready to go. And then we were told the drug wouldn't be ready for another 5 months. So we'd done everything we could. And then we had to go, oh. So we took the time and we tried to improve our patient information sheets and our posters. And we got lots of PPI input, so really good kind of PR and things like that. And we had our patient representative filmed the video. Great. Is it working? And I'm not going to dwell on this very long, and these are not going to be shared because this is from a data cut for internal oversight committee reports. But I wanted to see if any of this was working. Recruitment. So emergency medicine drug trial, we didn't know what was going to happen. We were really, really worried. We hit recruitment target last week, 3 months early, 8 months early if you count for the 5-month drug delay. This doesn't happen in trials. It certainly doesn't happen in ED trials and drugs. Yeah, we're still shell-shocked. So great, recruitment worked. But was it inclusive? Well, when we did this data cut, we only had 6 people who weren't approached because of language issues. We lost 9 because they were screened out by the site to do with breastfeeding pregnancy. And you can't really unpick anything about drug users. But overall, looked quite good. What about decliners? Well, we had 3 people decline because of language. Not too bad. 6 to 2 with contraception, so that's quite interesting. And again, we couldn't really unpick anything to do with the drug users, and that's partly, again, because of the way screening data is collected in the UK. Mean age, we were worried about the text messaging. We've got people up to 100 who were screened, people up to 94 taking part. Amazing! Sex, ethnicity, screening to randomised, not too bad. We did have a little bit of a drop-off in ethnicity between screening and randomisation, but we've still got 10% of our group, which we feel is really positive. And we recruited across the people we were thinking about, so that was really positive. Data collection, again, the text messaging was not being an issue, and we had a 94-year-old who was happy to send us text messages. So don't make assumptions, because we possibly did. No. And I could go through the rest, and basically, where we're at the moment, we're really pleased about how it's working. 92% of people will count as part of our primary analysis. Amazing. And we didn't find any issues around the different groups we were worried about. So that, not worried about the drug user groups, ethnicity, socioeconomic. We did across the board what we'd hoped to do. Results will be next year. Lots of lessons, lots and lots of lessons. I could go on and on and on. But PPIE, don't underestimate your PPIE and take them with you on the journey, because they've been amazing all the way through. But they're part of an enormous team. Trials are complicated, it's team science. You know, could list forever, but I wanted to leave you with some quotes from our patient co-applicant. Thank you.